Hi, I'm Dr. Matt Binnicker. Did you know that the Mayo Clinic Immunodermatology Laboratory has offered ELISA for immunobullous diseases for over 15 years? In this month's Hot Topic, Dr. Julia Lehman will discuss some important changes that are taking place in order to continue offering the highest quality testing. I hope you enjoy this month's Hot Topic, and I want to personally thank you for allowing Mayo Clinic the opportunity to be a partner in your patient's healthcare.
Hello, I'm Dr. Julia Lehman, Director of the Mayo Clinic Immunodermatology Laboratory and dermatologist-dermatopathologist at Mayo Clinic. I'd like to talk to you today about what to expect as we transition to a new vendor for our ELISA assays for autoimmune bullous dermatoses. I have no disclosures. Though rare, autoimmune blistering diseases, such as pemphigoid and pemphigus, can confer a considerable amount of pain and suffering to affected patients and can unfortunately contribute to increased mortality. Patients with these immunobullous diseases may present with tense blisters or flaccid erosions, although other atypical clinical features may be observed. For example, the possibility of pemphigoid should be investigated in older individuals with generalized pruritus, even when a rash is not present, or in the setting of an urticarial skin eruption or pruriginous eruption that is not improving with conventional therapies. In patients with chronic mucosal ulcerations or skin erosions, it is prudent to evaluate for the possibility of pemphigus. The diagnosis of immunobullous diseases requires integration of clinical features with findings on skin biopsy specimens submitted for standard microscopy and direct immunofluorescence, as well as serum studies for specialized testing. In pemphigoid, the histopathologic changes may include an eosinophil-rich subepidermal blister, which would be the most characteristic finding. However, changes may be more subtle, with only a sparse perivascular infiltrate with eosinophils, with or without intravascular neutrophils. The presence of eosinophilic spongiosis can be a helpful clue, although this finding is nonspecific and can be seen in a range of other disease entities as well. In pemphigus, the classic microscopic changes include acantholysis, or rounding up and separation of keratinocytes from each other. In pemphigus vulgaris, this process is often seen above the basilar layer of keratinocytes, or suprabasilar acantholysis, while in pemphigus foliaceus, this process typically affects keratinocytes high up in the epidermis. Often, the acantholysis in pemphigus foliaceus can be subtle and frequently is overlooked. While eosinophils and eosinophilic spongiosis can be observed in pemphigus, their presence is inconsistent. On direct immunofluorescence testing for pemphigoid, there is often linear deposition along the basement membrane zone with IgG and/or C3. While these features can support the diagnosis, they are also nonspecific and can be seen in other subepidermal autoimmune blistering diseases such as epidermolysis bullosa acquisita and bullous lupus erythematosus. In pemphigus, there is intercellular deposition with IgG, IgA, and/or C3. Subtyping of the particular form of pemphigus requires clinical correlation. Indirect immunofluorescence is typically performed using human salt-split skin substrate and monkey esophagus substrate. In pemphigoid, linear deposits of IgG are observed at the roof of the induced blister with salt-split skin testing, while in pemphigus, this study is usually negative. On monkey esophagus substrate, linear deposition of IgG can be seen in pemphigoid and between mucosal epithelial cells in a chicken wire type pattern in pemphigus. Though clinical and microscopic features are required for a diagnosis of pemphigoid and pemphigus, ELISA studies can improve diagnostic certainty. In addition, the literature supports their role in disease activity monitoring. In particular, BP180 and BP230 are sensitive and specific for pemphigoid, while desmoglein 1 and desmoglein 3 are sensitive and specific for pemphigus. These tests may also be positive in rare conditions such as paraneoplastic pemphigus. Results for ELISA testing for immunobullous diseases are semi-quantitative. That is, while the laboratory reports a numerical value as a result, the primary utility of the test is the interpretation of this numerical result as negative or positive, which is determined by reference ranges that are set by the kit manufacturers and corroborated in our own validation studies. For the last 15 to 20 years, we have used the same vendor for our ELISA assays. In recent times, we have explored other vendors' products. After extensive testing and discussions, we believe we can achieve even higher quality parameters by transitioning to the use of new ELISA kits. Testing accuracy should be about the same or perhaps better than before. However, you may note some new features associated with the reporting of results that would be good to be aware of when using these tests as part of patient care. Perhaps the most important change is the modified reference ranges, as you see here for desmoglein 1 and desmoglein 3 assays. While there was a category for indeterminate test results previously, results from the new test will be classified as either negative or positive. As before, results will be reported as whole integers. Reference ranges will be viewable with the test result, and abnormal test results will be flagged in your testing software. Importantly, there is no equation or calculation that can be used to translate prior test results to new test results. Reference ranges will also change for BP180 and BP230 testing. For lab testing results that exceed 200 relative units per milliliter for any of these ELISA assays, the result will be reported as greater than 200 relative units per milliliter. As is our current practice, results will be reported as round number integers. So, in summary, you will notice new reference ranges, which do not correspond quantitatively to results with prior testing kits. In addition, results exceeding 200 relative units per milliliter will be reported as greater than 200 relative units per milliliter. We hope you will also experience continued high-quality testing with enhanced testing consistency with the changes being implemented. Please feel free to reach out to our laboratory if you have any questions about our new test or how to interpret results in a particular clinical scenario. As always, it is necessary to interpret ELISA results in each patient's particular clinical context. We are proud of the enhancements we are making in the laboratory so as to be able to offer the highest testing quality possible for you and your patients. If you have any questions or requests relating to this talk, visit our website at www.mayocliniclabs.com. Thank you for watching this video.